Welcome back. Richard, it's great to see you again.
Good to be here.
Yes, it is.
Ready to go.
That's right. And today we're going to talk about a very interesting topic, very interesting and very controversial topic on dissociative disorders.
Right. That's right. Because this keeps coming up. First of all, there's two sets of three here. Mm-hmm. There are three dissociative disorders.
There are. Well, let's say that the reason that it keeps coming up is because I think I'm going to blame it on Dr. Google again.
That's a large part of the problem.
And say that, I have never experienced this before, where more and more people come in, mostly teenagers, young adults, come in claiming to have dissociative disorder. They say that they dissociate, that they have DID. They even use the acronyms. So they've definitely been Googling and searching this up online and talking about it through social media and different things like that. And so we thought that it would be really important to talk about dissociative identity disorder, what it is, and maybe more importantly, what it's not, so that we have a better idea as to, what's going on with dissociative identity disorder.
That's right. There was almost an epidemic of it for a while. It must have been making the rounds among teens, preteens and teens, both girls and boys in this case, young women and young men. So one of the reasons we wanted to cover this topic was just to sort of open it up, discuss it, clarify some things, and figure out what we want to do about it. So that was one reason. The second reason is many professionals are overdiagnosing this condition. As I said, there's a sort of now kind of an epidemic, or people are talking about it more, especially with trauma. Now that trauma has become popular, there's an easy segue to identity disorders. And the third thing is there's a lot of confusion, even among professionals, about this disorder, about these disorders. And when I say these disorders, there are three dissociative disorders, but the one that causes, I think, the most controversy is the dissociative identity disorder. Some people flirt with this depersonalization issue. And the third is dissociative amnesia, but that's kind of self-explanatory. That's if you've had a traumatic event, many times you either have difficulty remembering it or you can't remember it. That's amnesia. But this depersonalization is a little harder to get my arms around, at least. It has something to do with feeling that you're somehow disconnected from yourself.
Right.
Okay.
Yeah.
Now, what we have to remember is that 70 or 75% of people at one time or another, maybe many times during their lives, experience this feeling. So the issue is, when does it become a problem?
Right. Yeah.
And then the third is DID itself, which is really the major controversy here.
Right. Yeah. Dissociative amnesia, to me, that one is a little bit challenging from the perspective of, there's lots of times when we have a traumatic experience and we don't remember parts of it. From a psychiatric perspective, that's what dissociative amnesia is that it's sort of the argument that, your brain is protecting you from some aspects of the trauma. And so it's removing that memory or making it where you have sort of, put that memory back into the back storages of your brain, and you don't really have access to it. And so some argue that it's there. You just can't consciously pull it out and experience or, talk about it or think about it. And so you don't know. Which is a little bit different than amnesia caused by the trauma itself, like a head injury or something that creates an amnesia that because of a brain injury and you're swelling or something that just creates that. But yeah, depersonalization is fascinating because it's back in the 60s and 70s, there was that, people really started talking about sort of astral projection and some of those kinds of sort of metaphysical things. And that really falls in line with the way that people think about depersonalization, whereas, your identity or your essence has separated somehow from your body, and you're remotely looking down at yourself, or sort of watching yourself go through these different life steps without really feeling like you have a lot of control and those kinds of things. And yeah, we have all experienced, or most of us have experienced some aspect of that. But as you said, when does that become a disorder? When does that become something diagnosable? And I suppose, you have to think about when it happens without warning, and at times when you're not expecting it.
Right.
Yeah.
But clearly the problem is with the third, which is dissociative identity disorder.
Absolutely.
Okay? And as the name implies, to dissociate has something to do with a disconnection, or at least it's also a lack of continuity between our thoughts, our memories, our surroundings, our actions, and our identity. So there's some fragmentation of those things, and they sort of separate, they dissociate from each other, okay? And so with that in mind, so we want to focus mainly on the dissociative identity disorder, okay? And it is this failure to integrate various aspects of our identity, okay? Our identity, our memory, our consciousness into a single self. In personality theory, we talk about he has a fragmented personality, and that's a bad thing, okay? We all have multiple dimensions of ourselves, but we keep them in a coherent whole called the self. People who have a fragmented personality have parts of themselves moving in other directions. Okay? Right.
Yeah. We all, in personality theory, we talk about state and trait. And so, we sort of may have this overall trait of extroversion, for example. But yet there are times in our life when we are more extroverted than other times in our life. If you go if you're in an unfamiliar place where there's high demands placed on you and things like that, you may be a little bit more, withdrawn and quiet and pulled away from that social scene. Whereas if you're at a party and you're around familiar people, your full extroversion is going to be on display. So we have those broad dimensions that we present ourselves in. But yeah, as you said, that fragmentation, there's different parts of you that are working in very different directions, and sometimes opposing directions where they are contraindicated.
Certainly different, even if not opposing. And that's what we mean by the dissociation, is that there's this self and this self and this self, and they're distinct. They seem to be distinct, whereas most of us have a single self with multiple pieces.
Right.
Now, this is a mental disorder. It's considered a mental disorder, meaning that it causes significant distress or impairment. And that's, I think, the key here, is that many of us have these feelings, but it doesn't cause us distress. It doesn't cause us impairment. We continue to function pretty well day in, day out. And so it doesn't reach the level of a mental disorder. If it becomes impairing, then it would be considered a mental disorder.
Absolutely. And when we look at the history of DID or this sort of dissociative identity, which used to be referred to as multiple personality disorder.
Oh yeah, we should have mentioned that earlier. This was multiple personality disorder, and that's how many people still think of it as that. But the name changed. Okay, I'm glad you mentioned that.
Right, and so just to clear that muddy water, it used to be called multiple personality disorder. It's now called dissociative identity disorder. and it's not a personality disorder. We talked about borderline personality disorder last week, and DID, or even multiple personality disorder, whatever you want to call it, is not a personality disorder like borderline personality disorder. It's a very different condition. It's not the same thing. But when you look at it, and we think about, we'll get into sort of the diagnostic criteria and what we think about it diagnostically in just a moment. But when we talk about that, you can see how in the past, many times dissociative identity disorder, or people with some of these symptoms, they were often accused of being demonically possessed, know.
That's right.
Because their behavior would change so dramatically, unexplained, in an unexplained way, that the only thing that they had, conceptually, was that there was something else inside. And of course, at those times, they talked about demonic
possession. Right. And in some cultures today, that still exists.
Right.
So there's a fascinating history with this that goes it goes back thousands of years, but in 1791, there's this story, this account of a woman. They called it exchanged personality. It was a 20-year-old German woman who began to speak perfect French. She behaved like a French aristocrat and spoke German with a French accent. Okay. And when she was the French woman, she remembered everything she did, but as the German woman, she denied any knowledge of the French woman.
Right.
So there seemed to be a clear distinction and evidence. I mean, she spoke a different language. Where in the world did that come from? In 1811, just a few years later, 20 years later, an American, a woman from Pennsylvania, I have to chuckle about this one, and I don't mean that derisively, but can you imagine? She had a prolonged sleep, and she woke up, and she was a different person after waking up. So, and there are family memoirs that describe an 18-year span where she shifted between two personalities. Okay, and so there are accounts of this going back hundreds of years.
Right.
But the whole thing took a very definite turn in the 1970s when the book Sybil was published. Right. And I think everybody knows about Sybil, which is the famous, it was a book, and then it was turned into a movie. And so in the 1970s, this thing, today we would say it went viral.
Right.
Okay. Right. So this went viral in the 70s. The name itself was changed. We talked about the name change from multiple personality disorders, which is a nice descriptive term. In 1994, it changed and now called dissociative identity disorder. And that's the name that we currently use in the Diagnostic and Statistical Manual to talk about this fragmented or splintered identity. Okay.
Right. So when we think about the diagnosis, and there are other accounts for it. You can go to YouTube now and you can pull up, do search the 3 Faces of Eve, and those kinds of, and you can see videos of where clinicians have documented some of these experiences, and as we get into the diagnostic criteria, I think it is important here to mention that this is a controversial diagnosis.
It remains controversial.
Because it's really difficult to confidently determine that there's multiple personalities or multiple dimensions to a person's personality. When a person switches, and I put that in air quotes, when a person switches, there's no way to measure that outside of clinical observations.
Right.
We see it and those kinds of things. So if a person, thinking about the German woman that you mentioned a moment ago, how would anybody else know whether she had learned French at some other point in her life? And so she was putting on a show the whole time.
Right.
we don't know that. And so the best that we can do is watch the person over a long period of time and look for some of those consistencies. There are clinicians that will absolutely jump to that diagnosis right away, pretty quickly, which we would be very cautious of. But others, again, sort of experience or watch for that over a period of time as we look at some of these diagnostic criteria. So when we think about the current criteria from the DSM-5, as you said, the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition that just came out in 2013.
Right.
As they just came out in 2013, that was now 8 years ago.
I know, I keep thinking about that. It seems so recently, but a long time ago. Yeah.
So part of the criteria is that the person has to experience 2 or more distinct personalities or identities, again, it identifies that some cultures might refer to this as a possession, but each of them have their own enduring pattern of the way that they see things, the way they relate to other people, and the way they just think about themselves and the environment around them. But there has to be 2 or more, and that there is this change between them that happens. So
and there's a disruption. The second thing is there's a disruption that involves a change of who I am, or my sense of self, my sense of what I'm able to do, or a change in behavior. You talk about the German woman. There was obviously a change in behavior, but again, without some kind of confirmation, you have to wonder, and you have to be very careful. But there is this disruption of identity.
Right. And because of this, because of the person switching these identities, these personalities, there are gaps in their memories and personal histories. So the person may, when they're one personality, they may know who certain people are and remember certain aspects of their interactions from before. But when they are the other identity, they may have no memory of those things. And that's because those memories were formed when that personality was up front. And so the other personalities just don't know who they are. And of course, as you said a minute ago, it's a mental health condition because it causes some significant distress or impairment in functioning. So you have these, but that's the majority of the criteria there, so we have these 2 or more identities. There's a disruption that happens as they switch, and there's some gaps in memory.
Exactly. Yeah. So those 3 key principles, the 3 key features, I think are important to keep in mind. So you want to try to make sure that those 3 exist and find that there's impairment. Okay? Now, the trick here is to take these diagnostic criteria and make a differential diagnosis. And I think this is one of those areas where differential diagnosis is absolutely essential and key to this whole picture. So you have to distinguish it because of symptom overlap. You have to distinguish it from schizophrenia, because you have some of the same characteristics or features. Bipolar disorder, because again, the same thing. Epilepsy, because many times seizures can mask as this. You already mentioned borderline personality disorder. There are many common features between the 2. Autism spectrum disorder, and 3 others that frequently come up. One is malingering. Are you just putting this on? Are you faking? Factitious disorder used to be called Munchausen. And so are you just making yourself this way? There was an interview of a young woman a couple of years ago, and I think one of the cheap channel programs on TV did a special on this issue, and they interviewed a girl, and as she was talking about her many I think she had 13 personalities. They call them alters. She had 13 alternative personalities. And as you listen to her talk, you say, I just don't think any of this is true. And so you begin to wonder about Munchausen, what's called Munchausen, now called factitious disorder. And then there's this third, which is conversion disorder. People will will convert a psychological trauma into physical symptoms. Okay?
Right.
And so you have to make this differential diagnosis. It's absolutely critical.
Right. And the way that I think about the differences between some of those is, you know, malingering is usually done to get out of something, to get out of trouble, or to get out of some obligation or something. Whereas a factitious disorder is to get something,
get something, right.
Or get treatment or something like that. And conversion disorders are fascinating. They sort of fall into the category of psychosomatic disorders, and you know, there's a number of them in there.
Right.
But it is real physical symptoms that a person gets that's caused from a psychological root. And a conversion disorder specifically is when that happens from a neurologically, and it affects their brain. And so you can see it manifest in a lot of different ways. But yeah, differentiating these is really difficult sometimes, especially when you're talking about, I mean, imagine trying to differentiate these diagnostically with a person who, you know, if the person is experiencing some of these fractures in their personality, you know, so the report may be different at different times, their experiences may be different at different times. And so trying to weed through that, again, our perspective is that it takes time to weed through that stuff. And you can't just jump on that from an initial, you know, just as soon as you meet somebody.
Right. No, this takes time to peel to peel all these layers away and to make this kind of accurate differential diagnosis. When you have this many possibilities, you have to wade through a person's history very, very carefully.
Right. And it is very much a clinical diagnosis.
Right. Yeah.
You know, we can't, you can't do blood work or something like that to tell the difference. And I know you're going to talk a little bit about some neuroimaging,
which I was surprised by.
Yeah.
I mean, I was really, and this is in its infancy. There was a review article done in 2020 on the handful of studies that have been done. So this is very, very, very preliminary research. Right. But there are a couple of studies. There's a study that was done in 2018 that found that they could differentiate with 73% accuracy.
Right.
That's pretty high. But there is a glimmer of hope that perhaps there are identifiable brain structures that where there are differences that differentiate people with DID from persons who don't have it.
Right.
Mainly, it's where you would suspect it's those subcortical brain structures that create emotions, right? The amygdala and things we've talked about before. And we don't want to dive too deeply into this, but it has something to do with fear learning and movement and all the things you would expect, that there is some problem with these areas of brain. But I emphasize, it's in its infancy, and there's ongoing research, but there is some indication that there could be brain differences in these individuals.
Right. So let's talk for a minute about how in the world this happens, because it's, you know, this doesn't just come out of nowhere. It doesn't just, you know, a person doesn't just, although, you know, the examples that we gave say that this person, you know, the German woman just woke up one morning and she was speaking French. It doesn't happen like that out of nowhere. Dissociative identity disorder and all of the dissociative disorders, whether it's dissociative amnesia or depersonalization or derealization, all of these manifest following some type of trauma. The person experiences some type of trauma that that affects them in a way that can cause this fracture to happen in their personality. And so, you know, when we see some examples of some of these things, we might see the person, you know, the person's primary identity is there, but when they switch, you know, they may be, the new personality may be a much younger person. So you may have an adult, but the alter is, you know, 10 years old or something like that. And oftentimes that suggests that around 10 years old might have been when the trauma occurred. And so that person is sort of stuck there. There are some, Dr. Richard Schwartz, I looked down at the book, he talks about this internal family systems model that he has. And he talks about some of these aspects as a very adaptive thing that happens,
right.
You know, sort of before it gets to the point where it's causing some dysfunction and some problems in a person's life, that he sort of suggests in some ways that we all kind of experience this sometimes. The example is, you know, many of us will say, you know, well, there's a part of me that wants to do this, but then there's another part of me that says that. And he says that is sort of at the root of some of these dissociative aspects of our lives, because, you know, something that we experienced in our lives told us that, you know, doing this was a bad idea, whereas there's other aspects of our life that told us that it was a good idea, and we have these two sort of selves that we have to weigh out to determine what choice we're going to make, what decision we're going to make.
Right.
Now, of course, that's on the higher functioning end of this spectrum. It does get to a point where a person has absolutely no control over this from happening. But there is this wide gamut, and that different life experiences, especially traumas, inform these experiences and can cause the fractures that we end up seeing as dissociative identity disorder.
Right. Yeah, so it actually, for Schwartz, it actually serves a protective function. Okay. So the other thing, when we talk about diagnoses, and this is where we run into problems, before a person gets, and I can't emphasize enough how careful we have to be. And as you said, don't jump into this after the first or second or third visit. It's going to take more time than that. And it turns out that individuals receive an average of 4 misdiagnoses before they get to this one. And so it's going to take time, and and it takes many years to work through this, not only discovering exactly what it is, but then treating the disorder as well, because these are difficult things to continue to relive, even in therapy, even in a therapeutic session. Okay. So the problems with the diagnosis, one is dissociation lacks a precise definition. What exactly is it? What does it mean? Second, we have this overlap with PTSD, borderline personality disorder, substance abuse, anxiety, comorbidity. Usually a person has more than one thing. That's not uncommon. But the 3 that are most fascinating to me, and I know they are to you too, because we've had many discussions about this.
Yeah.
Media-informed self-diagnosis.
Right. Yeah.
I'll let you riff on that one, Berney.
Well, no, it's so challenging, and we did a podcast not too terribly long ago on about Dr. Google.
Internet-based Munchausen, right? Munchausen by internet.
That's right. But it's so difficult because you know, again, there's already the inherent difficulties with the diagnosis. But then, you know, a person, especially younger people, go online and they read about it and they say, you know what? And I think that it comes from a genuine place. They're really trying to figure out some things that are going on in their lives. But they go in and they say, you know, well, you know, I feel sometimes I'm a completely different person. You know, I can go here and I can act this way, and over here I feel completely different, like almost a completely different person. And they look that up and they come up with the DID. And so they think, oh, I must have dissociative identity disorder. And it's really tough, you know, from the clinical perspective to manage that sometimes, because people come in very confident that's what they have.
Right.
And so then you have to have this conversation with, you know, the vast majority of the time, significantly vast majority of the time, the primary personality doesn't know about the alters.
Right.
Doesn't know that they exist. They just know that they lose time. They just know that I don't. Yeah, there are hours in the day, or there are these times when I can't account for what was happening. Or I was talking to my friend the other day, and they said that I was acting really strangely, and I have absolutely no idea what they're talking about because I don't even remember seeing them that day. Those are the types of things that we typically see with authentic DID. But if you know the difference, if you know that oh, I'm a very different person in these kinds of situations, and this is what I do, that's probably variability within your typical personality that we often see. But media informed, you talked about the book Sybil. There was the movie recently, Split. And there's lots of examples in the media, print and visual media, about dissociative identity types of perspectives. And it's, people come in very confident that that's what they have.
That's right. And the first thing you have to do is walk them back a little bit,
right,
to get to some neutral point, and without offending them,
right,
without saying, oh, this is stupid. They're bringing you, they're presenting a problem to you, and you have to be careful with that. You have to be gentle with that. Okay. So media informed self-diagnosis. The second is too many alters. And I said alters are the alternate personalities.
Right.
1944, most cases averaged 2 alters. By 1997, there was 15 or 16 alters. And so as the awareness of this increased, the number of alters increased. And I think that's a problem of a clinician creating that problem, that it started to get out of hand.
Right. I've talked to clinicians who are huge, I don't know if I should say huge proponents of this diagnosis, but they see a lot of people with these types of difficulties in their practice. And, this referred to, people as having hundreds, if not thousands of different personalities. And it's like, it's difficult to wrap your head around what in the world that means.
It'd be difficult dealing with 2.
Right.
You've done it. I mean,
right.
You've done it. You've seen patients. And it's difficult managing just 2 different personalities.
Right.
What do you do with 20? I mean,
right. So it's difficult to, and then again, you're trying to make sense of it, especially when it's a younger person, because, the idea of having 15 different personalities, but you're only 17 years old. So it's like, okay, how does that work? The trauma would have had to have been really significant over a long period of time. And even then it's hard to process from a clinical perspective, how that could have happened. And so yeah, it's like a lot of other conditions, a lot of other disorders, we start to dip our toe into that clinical water a little bit, and then all of a sudden we're drenched, and it's all over, and we have taken it from what it probably is in reality to this massive concern.
Right. Yeah, and the final thing, one is too many alters, but the other thing is there are in many cases there are therapist-induced DID. Right. And I think the saddest case came out, I think it was in Dallas, near Dallas, that between 1991 and 1997, over 500 cases of dissociative identity disorder were admitted to a single practice, to a single dissociative treatment center. It's just, that raises alarms. To me, it raises alarms because, first of all, this is a very rare disorder.
Right. And
to have 500 in one place would be exceedingly rare, because we're not talking about something that affects 20% of the population, as depression or learning disabilities or ADHD might, or not even ADHD, but learning disorders or depression. This is not like that. This is a very rare condition. And to find 500 in one place makes you wonder where the diagnosis is coming from.
And there have been reports about that situation, that case. And there were like Dateline types of news magazine shows that talked about that. And it was demonstrated that, you know, most of those cases, the clinicians induced it from in that, you know, they said they would encourage the person to talk about different personalities, would encourage the person to differentiate, you know, the decisions that they would typically make from these other decisions that they made. And you know, just because they made different decisions in different places, refer to that as two different personalities. And clearly that's problematic to think about it or even conceptualize it that way, and to talk to a patient about it that way. I make very different decisions in one setting versus some other setting, but that doesn't mean that I'm a different personality. That just means that, you know, the setting calls for something different. And we have to acknowledge and talk about these things in that way.
Right. Okay, so our take on this disorder, first of all, caveat emptor, unless you're absolutely certain, don't buy this from anybody until you're sure, and you're not going to be sure in a visitor too. Okay, this is a rare disorder. It doesn't occur often, and you have to be very, very careful that you're working with a skilled clinician who isn't rushing into a judgment.
Right, and that's part of that caveat is for the clinician. You know, if a person comes in complaining about things, don't just jump to that diagnosis. You know, pause for a minute, you know, watch the person over a period of time, you know, really explore some of the symptoms and characteristics and make sure that that's the right diagnosis. Because it is rare, you know, it doesn't happen very often.
Right. Second, be careful with recovered memories. I think there's enough evidence now, even in the news and popular press, that recovered memories are probably not accurate memories.
Yeah, you know,
probably not accurate.
When we think about, you know, and we're not going to get into the neuropsychology of memories. Won't do that. However, you can change when done in different ways. You can change a person's memory, and they have no idea that you're changing their memories.
Exactly.
The use of different, you know, when a child or someone discloses that a child has been abused, you're only allowed, in our area at least, you're only allowed to interview that child a couple of times, because we know that the more that the child is talked to about it, the more the different number of people who talk to the child about what's happened, you know, a word said here or the way the question is asked there is going to create some adjustments in the way that they remember things. And then all of a sudden, you know, you get to a point where the kid is has completely changed their story, but absolutely believes that that's what happened. Because they can't appreciate how it's evolved over time. Our memories change with each experience that we have after an experience. That memory keeps changing, and so be mindful, be careful about recovered memories, because you don't know how authentic they are, and it has nothing to do with faking it. It has nothing to do with confabulation or anything. Genuinely speaking. So yeah, be careful.
Right. And then if you can get a second opinion, if you can't get a second opinion, make sure you and the professional have worked through this very carefully, very methodically, and that you get some confirmation from other people, family members or friends.
Absolutely.
It's not always possible to get a second opinion, but when you can't, then just proceed cautiously. Also, if you do get the diagnosis, be very, very cautious, be suspicious if the professional starts talking about numerous 10 or 12 or 15 or 18, what we call alters or alternate personalities. Begin to get suspicious if somebody's trying to sell you that, because if somebody's saying you have 15 or 18, you're looking at a lifetime of therapy. Possibly. And so be careful. Be very careful with this one.
And with all of that in mind, you know, if a person is presenting this, if a person fears that this is what's happening to them, I think it is important that we ask that question. You know, what happened to you? What is
Exactly.
There's that great book that just came out not long ago, written by Oprah and Bruce Perry, Dr. Bruce Perry.
Right.
The book is called "What Happened to You," and they talk about the long-term effects of trauma.
Right.
And this is one of the risks of long-term risks of early trauma. And, you know, talking about what happened, what experience the person has had in their life is really an important way to explore some of these possibilities and to delve a little bit deeper into this. Treatment for this is exceedingly difficult. Right. And you said lifelong. It takes a long time, because the goal of therapy, of treatment, is to reintegrate, is to bring those personalities back together. And I don't know another way to say it except the personalities tend to oppose this. They tend to not want this, because in essence, you know, if you think about, you have these two identities.
Yeah, right. You have them for a reason.
To integrate them means that one of them has to go away.
That's right.
Another way to say that is one of them has to die.
Right.
And they don't want to. They don't want to go away. They are worried about the other, their primary identity, or they're, again, as you just said, they're for some function, some purpose, and they don't want to. And so it's going to be really resistant.
Right.
But that's the goal of treatment, and it takes
a long time.
And there are treatment centers around the country that help focus on this, but it's really difficult.
Yeah, because you always have two issues here, two big issues. One is you have to deal with the trauma.
Right.
That alone is a challenge.
Absolutely.
Because people don't, as Schwartz said, we don't want to look at this stuff.
Right.
And you have to be very careful when you're asking people to revisit these traumatic events. Right. So you have the whole trauma issue. Then if you deal with that successfully, now you have the identity issue.
Absolutely.
Which could take even longer.
Right.
Okay. So it's a very, very complicated and can be a very time consuming process.
Absolutely. So be cautious, be mindful. You know, folks, don't, you know, just go with what you're finding on Google and, you know, just do all that confirmatory stuff that we do and find all the examples to demonstrate that, yes, this must be what I have. It's very rare. It's very difficult and very, you know, it really affects your functioning and can cause a lot of problems for you. So if you are worried that this is what's happening, you know, go see a trusted professional and talk about it and really delve into it to explore what's going on and get some help.
And be mindful of those cautions, those caution flags. You know, if somebody starts moving in those directions, listen carefully, but be careful.
Absolutely. So, all right. Well, that then is it for today. Until next time, stay happy, stay healthy, and forget to be afraid.